Alrighty. Hi, everybody, and welcome to AHI New Mexico this morning. It's a very nice morning out there, and we wanted to welcome you and go over a few slides here. We're required to go through these for every webinar in order to offer you the CMEs and CEUs that we offer. And Dr. Matson, if you could go ahead and advance that slide for me, I'd appreciate it.
I'm trying.
We're probably not selected on the PowerPoint. Just click on it.
There we go.
Okay, great. And the first thing is we are broadcasting live and recording. So if you do have comments or questions, please don't include any confidential patient health information during the session. Next slide, please. And if you do wish to receive a CME or CEU attendance certificate, we do need to have you announce your name. You can do that through the chat box, or in just a moment, we'll have just a minute to announce your name. We'd love to have you on audio and video if possible. Next slide, please. And your computer video and audio are down. Typically, they're in the bottom left of your Zoom screen, so you can toggle those on and off. We do ask if during the presentation that you're muted, please, and when you're ready to ask a question, go ahead and unmute. It just keeps the recording and everything a little bit happier. Next slide, please. And our disclosure and accreditation statements are on the screen. That's for our CME policy. Next slide, please. And we do offer case consultations for AHI New Mexico and some of our other telehealth offerings. So if you do have cases that you'd like to bring, Blue Cross Blue Shield and Molina Healthcare do reimburse for those. And it is a pretty significant amount of money. So $75 and $150 were the last number we heard. Not sure where they're at this point, but we're trying to gather that information. If you have any questions on that, just send me an email. It's kwarling@salud.unm.edu, and I'm also at the end of this slide set. Next slide, please. And at this point, let's go ahead and do roll call. If you're out there, if you wouldn't mind, just let us know who you are and where you're from. And we do have a few people who've chatted in now. Colette Love Batista. Sandra Fortier at Spartan. It looks like we have a Donald Rodarte as well. And I imagine some others will join us as we get going here bright and early this morning, here in Albuquerque anyway. And I will go ahead and, well, this is Kevin Worling, systems analyst here at Envision New Mexico, and we also have with us in the room.
I'm Jane Beckley. I'm a nurse practitioner with Envision New Mexico Fronteras Grant.
And hi, I'm Carol Conley. I'm an education and outreach manager, social worker by training here at Envision New Mexico. And I want to welcome you all to Studio Envision for this day's talk on opioid addiction in adolescents. If you are interested in receiving a certificate for this adolescent health initiative, please reach out and let us know, and we'll give you those details. So without further ado, I would like to introduce Dr. Steve Matson. He will be our speaker today. He is the Section Chief of Adolescent Medicine at Nationwide Children's Hospital and Division Chief at the Ohio State University College of Medicine. He currently serves as Medical Director at the Franklin County Juvenile Detention Center and is President of the Ohio chapter of the American Society of Addiction Medicine. He is a member of the Opioid Medical Support Clinical Advisory Panel for the state of Ohio, the Credentialing Committee of the American Board of Addiction Medicine, and is a consultant to the Society of Adolescent Health and Medicine Clinical Subcommittee for Alcohol and Other Drugs. Dr. Matson has published widely on substance abuse and substance abuse treatment in adolescents and is considered a national expert on this topic. He is board certified in general pediatrics, adolescent medicine, and addiction medicine. And I just want to say I had the good fortune of hearing Dr. Matson's talk here at the University of New Mexico. It was a really good talk. It inspired us all. gave us hope about working with our adolescents, and I am so grateful to you for taking the time to come and do this talk again. So without further ado, Dr. Matson.
Good morning, everyone. This is a new thing for me, so please shout out if I'm doing something crazy here. Speaking to you from Columbus, Ohio. I was just thinking I'd rather be there looking at the Sandia Mountains rather than this here in Ohio. Doing a little green and red sauce and trying to figure out which button to push there in Albuquerque. You know, I've been practicing adolescent medicine for 30 years. The last 10 years doing the medication-assisted treatment, and I can tell you it's really the most rewarding thing I've done in my whole career. It's such a terrible problem. These patients are so stigmatized that they really feel like the healthcare system has deserted them. And it's such a nasty disease, and amazingly some people really get better and beat it. So I can't find anything more fulfilling than that to do in my lifetime. This is a young lady that started out when she was about 18 with us. Now she has one child, has been free of drugs for 6 years, I think. So what I want to talk about today is a little bit about just what is addiction, what the new definitions are. I dropped out the stuff about what teens are using just to try to give more time for this talk, but it's in the notes, so feel free to look those over. So looking at the epidemiology of opioid abuse, kind of look at how we evaluate and treat this disorder, looking a little more at medication-assisted treatment, and then some outcomes. So I think, you know, the new way that people should be thinking is that this is a real disease, it's a real brain disease, and it's a brain disease that can actually get better. I always say when I was a resident that we used to see a naughty little 3-year-old and we'd just say that kid's going to jail because we were taught the brain was done by then and nothing more was going to happen. But we sure know now that lots of changes occur through adolescence, and even the brain can repair itself, which we never thought could happen before as well. So I think the one big thing is we got to get rid of this old punitive model of addiction. The stigma is really a big problem for people seeking help, and this idea that addicts are weak and they should be able to pull themselves up by their bootstraps is crazy. You know, that they choose to use drugs, it's not something they're forced to do, and basically that they should be punished and not treated. So hopefully that's going out the window, although it's still pretty prevalent in many healthcare delivery systems. So hopefully we'll get rid of that and understand that it's really a brain disease, it's chronic and relapsing. This just shows back in the 1999's late, the early research looking at the effect of how dopamine responds to things. Dopamine is really that pleasure neurohormone in our system. Showed when rats ate, their dopamine went up. When they had sex, their dopamine went up. Then they took it a little further and tried drugs, and with amphetamine, cocaine, nicotine, everything is really driven by that huge dopamine rush that everyone's chasing. This was a booklet that came out recently, and it just has a nice little diagram of how the cycle of addiction works in someone. Prefrontal cortex is that area that you start thinking about things, remembering how pleasurable it was. And in fact, just thinking and planning starts to shoot that dopamine off, feeling better. You use the drug, feel fantastic, which unfortunately for them wears off pretty quickly. The locus coeruleus is the area that really starts making people feel bad. And really, once they feel so bad, the cycle just keeps going round and round. And we know that the brain changes, which makes this disease so hard to treat, but usually dopamine comes across the synapse here and binds and gives pleasure. So here on a normal person, dopamine's being released, binding to the receptor, and this is how a normal brain looks. After somebody's been abusing drugs for quite a while, these receptors downregulate, so there's fewer, requiring more and more stimulation to get any response. And this is really what all brains look like of people, and this is just showing different drugs: cocaine, methamphetamine, alcohol, heroin, all do the same damage of decreasing the dopamine receptors in the brain, requiring massive amounts of drugs to get people to feel okay. So really the new definition is that this is a primary chronic disease of the brain. It affects reward, motivation, memory. Dysfunction leads to pathological pursuit of drugs. Like other chronic diseases, it's normal to have cycles of relapse and remission. And unless we really treat this and get people better, there's a really good chance they're going to have a really bad outcome. This is just showing, using that chronic disease relapse model, that here's drug addiction, usually around 40 to 60% chance of relapse. But if you look at other diseases similar, diabetes, hypertension, asthma, all of us that have treated people with these conditions know that it's very common that people relapse, get sick again, and need reassurance and need more input into their health to get them better. So very similar disease. I always tell people when I first meet them that, we know there's a really good chance you're going to relapse. So I want you to know that I know that's a normal part of this disease, and that you feel comfortable telling me about it, and we can address it and try to decrease those relapses in the future. I'm a pediatrician, as you know, and it seems like we're missing the boat on this, because virtually every opiate addict starts using drugs when they're adolescent. And of course, the headlines are there, and a lot of money is being poured in to try to treat all these people that are opioid addicted. But it might be nice if we actually caught young people when they're transitioning to weed and alcohol, and to stop that transition before they move on to more difficult diseases. We really know about 90% of all those who are addicted to alcohol, tobacco, or drugs start before age 18. And about a quarter of people who start using before age 18 become actually addicted or dependent on substances. So I know prevention doesn't always get all the headlines, but it seems like we could be doing a lot more preventing the people moving on into these difficult problems. So let's look at what's going on in this country. These numbers, I work with it, and they still just blow me away. I can't understand why people aren't more concerned, but this is a recent study that's looked at the numbers from January through June of 2017. Each dot represents the past 12 months. So back in January 2015, 47,500 died from drug overdoses. And in 2017, as of June, 66,817. I'm pretty sure if that was an infectious disease or something, people would really be going crazy about it. But again, I think the stigma, there's that unfortunate idea that some people are getting what they deserve. That's a lot of people that are dying every year. There's just an interesting little map that looks at county rates of drug overdose, and this started in 1999. So this is where I live, up here. Really all got started in West Virginia. A lot of coal miners and that were chronically injured were using opioids prescribed by their physicians and started running into trouble. And you've got a little area right there, I believe that's the Rio Arriba County, which my understanding is there's sort of a generational use of opioids going back to the Vietnam War and some other places that started that area very quickly. If we move on to 2016, you can see pretty much the whole country is involved. We are very red over here in the Ohio, West Virginia, Kentucky border area. You guys are pretty high up there too. And remember, this is death rate, so it has to do with your how many population and how many are dying. So your little lower population, luckily not as many people are dying, but still the rate is pretty high. So again, 66,000 died from June 2017, and this is all preliminary data, so that number is probably higher. Right now, drug overdose is the leading cause of accidental death in the U.S., more than car accidents, homicide, or suicide. It's the #1 cause of death now for people 50 or younger in this country. I think that's amazing. And really, the opioid addiction is driving most of it. You can see about 30,000 from the prescription pain relievers, 15,400 from heroin. So it usually runs about 80-some, little higher percent of all the overdose deaths are due to opioids. Just gives you a little idea of what states are having significant problems. This is death rate again, so it's deaths divided by population of the state. You can see our neighbor in West Virginia is leading the country in overdose deaths per people in the country. We're #2, and then things go down. You all are #13. So it's affecting a lot of people really all over the country. If you look at sheer numbers, Florida has the most deaths, almost like 4,700, 4,800, California, Pennsylvania, and we are up there at around 4,200 deaths. 4,200 deaths in a year. To me, that speaks to be the major public health issue that people ought to be addressing in this country right now. Just looking at New Mexico, so the yellow is the actual drug overdose deaths. So you've actually gone down a little bit. So you must be doing some good work out there. I'm not sure any other states have done that. And then the opioid is in the pink here. So you see about the same, about 80% of all these overdose deaths are due to opioids. It's a little old, but from 11 and 15, so you can see where your hot areas are. Albuquerque's coming up, the same, Rio Arribe. So there's obviously hot spots in the state where this is a bigger problem than other counties. I think the same thing is beginning to happen in New Mexico, which may lead to a bigger increase in overdose, and that when you can see back in 1999 that most of the deaths were due to natural and semi-synthetic opioids, so basically prescription opioids, and very few due to heroin and fentanyl. But if you come forward now to 2014, you can see that heroin and fentanyl are starting to take off, and my guess is it's taken off even more in the most recent years. So the general transition from prescription opioids, people crack down on prescribing, make it a lot less available, cost, and convenience actually leads to the use of heroin. Heroin still in Ohio is about $10 a dose, as opposed to like 40 or 50 bucks for a oxy. And the business model actually of the people that are bringing opioids into the country is quite excellent. They usually have a phone number. You can order the heroin by phone. They bring it to your home. They call you back the next day to make sure you enjoyed it. And if you did, would you like some more? So a lot less dangerous in many ways than having to go downtown in a dark area and exchange some money for some pills with someone. And just a reminder of the fentanyl taking off. Everything's judged by morphine. Heroin's about 3 times stronger. Fentanyl's 80 times stronger. So if somebody really goes from heroin to fentanyl, they're going to overdose and die. And I think you've even had some of this carfentanil that's come around. About every other month or so, we'll get 30 or 40 people that died because some carfentanil was laced into the heroin. And carfentanil is used to put elephants asleep, so you can tell that that's a very dangerous drug. It's hard to understand why people would mix that in there, because you obviously don't want to kill your customers. But I think for some people, you know, the heroin has been used so long, they've grown so tolerant to it that they're constantly looking for a little bigger high. So they're not exactly pharmacists, but they try to lace a little bit of stronger medicine in there to get people feeling better and obviously get some pretty bad outcomes. If you just look at teenagers, you can see there's about 276,000 adolescents that are using pain relievers without a prescription, 122,000 that are addicted, 21,000 are using heroin in the past year, 5,000 current heroin users, and 6,000 people with opioid use disorder. And then to top that off, we know that treatment is pretty poor and not very available. So this a little old again, 13, 14, but I'm pretty sure it's not much different, that those reporting needing treatment but not receiving it. And then looking at here, so the darker colors are higher. So in New Mexico, if you use those numbers, there were about 6,000 youth that had a substance use problem but were not getting treatment. And in Ohio, we have quite a few more, 27,000. So their treatment is not that available even for adults, much less available for minors. So how's it happen? I'm going to try to play this video. It may not work. Let's see what happens. And if you can't hear it, I will send you the copy.
Dr. Matson, I'm sorry, we're actually not getting any sound now.
Okay.
Sorry
So
about
this
that.
young lady started using weed when she was 16, transitioned onto pills when she was 17, used heroin for the first time when she was 18 because she didn't have any money and she had to get high. Initial use was fantastic, and then after that, basically her life was ruled by the heroin, getting up every morning, getting out, trying to hustle some money and using, and she basically says that she didn't know who she was anymore. And I think that's a fairly common story, especially with us, and it speaks again to the prevention that a lot of people that are older now, they're using heroin, started using when they were 17, 18. And, you know, they just are not coming in for treatment. And many of them start to learn to get high with marijuana. You know, it's really the first drug that they try that gets them high. I seem to be one of the few people against legalizing marijuana, but of course I'm seeing the skewed end of it, that kids that are using it, especially early, you know, if kids start smoking weed when they're 12, 13, we know that they have a significant higher risk for going on to have a substance abuse problem when they become adults. So if you were going to think about some prevention messages, obviously for kids, try not to smoke weed. If you gotta do it, wait until you're older. Even if you could wait till you're 18, 20, your chances of having difficulty with it are much lower. Basically, you know, people panic about substance abuse a lot, but basically everybody just needs a comprehensive substance abuse assessment. Once you get that assessment done, that basically drives the level of care someone needs. Somebody's drinking a little bit of alcohol or had an accident, you know, they might do well just with an educational program. Somebody smoking weed 5 times a day, every day, dropping out of school, can't hold a job, that kid probably needs a lot more intensive intervention. I'd say right now, if we could get every one of our youth that are abusing heroin into a decent residential placement, that would be the best, because the biggest problem we face is the environment that they go back into. Often parents are using, or grandparents. They're right next to the people they've been getting drugs to, so it's easy access. Most people aren't ready to go into residential right away, and so that's where our MAT comes in. So what can we do for this young lady using heroin? So you can spend almost $100,000 in a drug wilderness rehab program where you get away from everything. I'm not sure that's the best treatment, but it might work for some people. So we really need a lot more affordable, accessible care. So the treatments we have right now, the non-pharmacologic would be residential, intensive outpatient programs like 3 hours, 3 times a week, 12-step. I think I was initially cold on 12-step, but I've come around and believe, it's worked for a long time. I do think, younger people need to be around younger people, with some older people that have some sage advice, but it's really, when everything else is done, it's what's left to keep you safe. So I think people trying to find a place that they can feel comfortable with is really important in the long run. Obviously, other ideas. So the pharmacologic things we can do the replacement therapy, which we'll talk a little bit more about. Methadone is still out there. I would say it would be pretty unusual to start a 17, 20-year-old on methadone. Usually it's something that's reserved for people that have failed kind of recurrently on other treatments. The buprenorphine, which we'll talk about. Withdrawal-based treatment really has not worked. People come in, they get a little buprenorphine and then taper them off and send them home, almost universally relapse. And then there still is opiate blocking with the naltrexone or Vivitrol, which we'll talk just briefly about. So why do I think it's good? Without using the replacement therapy, the chance for relapse is really high. Opioid addiction has a really high Q response, so somebody walking down the street sees an insulin syringe, their brain just goes crazy and they need to use. It sounds weird, but it really does happen. Or, they see something that they've always associated with their using. If you aren't blocking that response, it's really difficult. They go to the dentist and get some opioids, they cannot take opioids. These cravings and preoccupations, if you don't still them, they're never going to be able to sit still long enough to learn some coping mechanisms. Obviously, behavioral treatment is important. It tends to be very difficult to find. So, and there has been some research showing that MAT with like motivational interviewing and just some coping skills can work pretty well. So, if you can't find a perfect substance abuse behavioral treatment program, I think you can get relatively good results if you learn a few other skills. So how's the buprenorphine? One of the most common forms is Suboxone. Suboxone is a combination of buprenorphine and naloxone. The naloxone was put in there so that if you try to solubilize the medication, you'll get a bad response because the naloxone will go into the blood. The naloxone gets broken down in the stomach, so it doesn't affect people that are using it properly. This just kind of shows how it all works. These are little opioid balls, and when they bind to the mu receptors, you get all this good feeling from the dopamine coming out. As the opioids start coming off the receptors, you start to get that negative effect, and as more come off, more and more negative effect that drives that future use. So buprenorphine is also, it's actually an exceptionally good pain med. Buprenorphine is a partial agonist. So when it does come down here and bind to the receptor, you see not quite as many pluses. So it blocks the euphoric effect. It gives you a little bit of a effect so that you aren't going into withdrawal, and very strong affinity for the receptor. So you show here if somebody takes like some heroin, if they're using their buprenorphine properly, it'll bounce off, just ricochet off, because that buprenorphine won't let go. So if people are taking their medicine properly, it's very difficult to overdose. These are just some of the forms. Originally it was pills. We prefer the films now just because they dissolve a lot faster. Many insurance companies, of course, are making us use the pills because they're cheaper, which is pretty annoying. And then a few other forms of Zubsolv. Buttaval is something a little bit like some tobacco. You put it in between your cheek and gum and hold it there. So our treatment goals are really to get rid of withdrawal. People that have been using for a year or so, they're just extremely fearful of those symptoms of withdrawal, and they don't want to have to deal with it. And we know that people have been using for a long time really have a reset of their pain tolerance. So most people that have been abusing opioids for a while have a very low tolerance for pain. And it almost seems comedic sometimes, but they just are so sensitive to it that you really have to try to relieve that pain if you want to have any hope. And really, so block the euphoric effect of anything that might use on top. Probably the biggest thing is getting rid of that craving. The craving is just that hamster on a wheel that just keeps going and going and going. That's going to really force people to not learn much else other than trying to think about using. So really got to stop that, decrease the overdose death. Obviously, hepatitis C, HIV. We've been lucky here in Ohio. We have not seen a big outbreak in HIV, but about 40% of our even young patients are positive for hepatitis C, and try to improve their function. So the benefits of trying to do it in the office, I mean, we can usually see somebody within a day or so, rather than if you're trying to hook up into an official treatment center, which often can take months. I think coming into a regular clinic, nobody knows who's addicted to heroin versus somebody coming in for a checkup or coming in for contraception. So it offers a little bit more, quite a bit more confidentiality for people. Kind of fits their lifestyle. We don't have to see them every day like a methadone clinic does. They don't have to leave the state to get treatment. And obviously it's quite a bit cheaper than residential treatment. If parents are sound, you know, it allows for parent involvement. And really, it is amazing. It's obviously not a cure, but I say when I might see a young 17-year-old kid who's been using opioids for a year, we get them on the buprenorphine, and they're basically normal in about a week. Doesn't mean they're cured, but, you know, they feel normal. They are able to get back to school, maybe get back into a job, and become part of their family again. So how do we do it? Like I say, we try to integrate it into our adolescent clinic. I think the benefit of the integrated type services is that obviously substance abuse is usually not an isolated problem. There's lots of other things going on. Young people need contraception. It's cost effective, reduce that wait time, and take, really we can do a lot more care coordination. So basically a new patient comes in, we do a complete substance abuse assessment, physical exam, we're looking for track marks, infections, endocarditis, abscesses. In fact, most of our kids don't look too bad when they come in because, you know, they've only been injecting for maybe 6 or 12 months, so we're catching them early. We always do a point of care urine drug screen, which has been really helpful for us to be able to do that right away so that we can know what's in their system at that time. Ours has a methadone test in it. Methadone's tricky. If somebody has methadone on board, we need to wait till that clears out before we start the buprenorphine. And because it has such a long half-life, the methadone, we gotta give them just a little symptomatic relief until that methadone clears. So we review our urine drug screen. Right now it's law in Ohio. I don't know if what's in New Mexico, but if we're gonna start someone, you have to look at the prescription monitoring program every time you see the patient to make sure they aren't getting illicit other opioids or stimulants from other doctors while you're doing that. Basically, we've gotten to where we just induce them at home. I know when you read the little things of how to do things, they talk about giving 2 milligrams and waiting and 2 milligrams. To me, you know, that's just so dangerous because you got to have the drug on site and people find out about that. And in fact, we've had very few problems with just home detoxification. We found that by the time people are injecting heroin, usually 6 to 10 times a day, that they're going to need what I call a full dose, which is 2 of the 8-2 milligram films. Although people say to give it once a day, we've just found that with their sort of addictive behaviors, they like being able to kind of do it twice a day to kind of affect their feelings. We can prescribe other medications, but in fact, most of the time the buprenorphine works so well that most people don't need any. I think for the kids that have a adult around, basically we suggest a home lockdown, only school, work, rehab. Got to take that phone away, which is basically their lifeline to their dealer and their drugs. Delete the contacts so it's harder for them to call people. Make sure they're taking that medicine right. It is a little tricky. You got to put it on the tongue, under the tongue. You got to leave it there for a good 10 minutes. Even though we spend a lot of time telling it, we still get kids coming back and they're swallowing it and doing things. So it's really important to continue to reinforce proper technique. And the medication is like gold. So it's, you know, one of the big issues is basically putting money in the hands of somebody that's a substance abuse addict. A Suboxone film probably will go for like $50. So we definitely have people who take one and sell one. I think it's not as common as people think, and you got to remember that people aren't really abusing buprenorphine. They're using it to not go into withdrawal. So it's not as if that, but money can be made. So we try to be as careful as we can. We make people bring their film packages back, count them, try to make sure everything is good. Try to be very firm about lost or stolen doses. We have a contract that they all sign at the beginning, which basically says they should not sell, they should not, you know, and that if they lose doses that they are not going to be replaced. Kids like put it in their car and go somewhere and it gets stolen. Just gotta try to keep a little bigger handle on it. Obviously with every first patient, we send them all home with an overdose kit. In the old days, we kind of put one together, but now a company is making this extremely easy to use system. It has 4 milligrams of naloxone in it as opposed to the 1 milligram. All you got to do is jam that up one nostril and push it in. So super easy, higher dose to give you a fighting chance against fentanyl. And 2 of these come with every prescription. And it's relatively cheap. So it, like here in Ohio, it's being covered by Medicaid. We usually see them about every 7 to 10 days, make sure they're with the program. Once they're attending some treatment, continuing to be abstinent, we start stretching it out every 3 to 4 weeks. A lot of our kids have mental health problems. I would say at least half. Many kids like continue to smoke weed because of their anxiety and social phobia. So it's really important to try to make a decent assessment of mental health problems once everything is kind of cleared and stabilized. The use of heroin, obviously, can make people look like they're anxious because they're constantly thinking and wanting to use. But many of them will have depression, anxiety, and I think in our guys especially, a lot of attention deficit. So we usually do not restart stimulants right away, but if our patients have done well like a year, we'll carefully add in a non-abusable stimulant, and you really can notice a significant improvement with that. We know many people with attention deficit are high risk for going on to abuse substances. If they're not treated, I think a lot of people kind of stop treating people when they hit adolescence, but might be the most important time to continue them on those meds. So how long do you have to do this stuff? Pretty long, actually. At least my viewpoint, that we know from the brain that the changes that occur from the use take about a year to return of not abusing drugs. So it is very rare if somebody's doing well with us that we would start to think of weaning before a year. So most people maintain that high dose of 16 until they really are getting stabilized. I changed this in your handout, so if you wanted to mark it, I'd say stable for 12 to 24 months before we really considered a taper. And then it's super slow. We let the patient tell us if they're ready to do more. So it can take a year, 2 years, 3 years sometimes to get them down. I'd say at this point about half of our patients actually go off the medication. Another half are maintained on a really low dose, like 2 milligrams every day, which is probably a little bit of a psychological crutch, but if it keeps somebody from going back to becoming addicted to heroin, I think that's worth it. That's another debatable point with a lot of people, but I kind of see it like mental health. In the old days, people used to think you might need your Prozac for a year to feel better, and turns out a lot of people need it forever. And I think the same thing is true with the buprenorphine. So how are we doing? This is from our early days. You can see that only we lost 25% of people even after the first visit. By 60 days, we were down to less than half, and by a year, only 9% of our patients were hanging in there. So I'm sure you got quality out there, but we built a huge quality project to try to see how we could improve that. And here's what we found. To really welcome people, I think they're so used to being treated like crap. So I'm so glad you came. I think we can really help your life out here. We're going to make your life a lot better. If you can just work with us, things are really going to turn around. I think originally we were kind of scared of the DEA, and they do come calling, but so we were being very strict and kind of pushing treatment very fast, and I think we scared a lot of people away. So now we really have pretty minimal requirements. Take your medicine properly, try as hard as you can to not use any of your illicit drugs, and come back for your next appointment. That's basically what we tell everyone now. And I think they appreciate that a lot better. I think we continue to say, there's almost nothing you can tell me that's going to make me kick you out of our program. So I just want you to be truthful. And they are such good liars. I always thought as an adolescent medicine doc, I was one of the best lie detectors. But these kids have been lying for so long and doing it so well that it's really hard to catch them. So trying to get them to be comfortable telling the truth and not having to suffer consequences, I think is important. Obviously, MI. We do some contingency management if people continuously use drugs. We will decrease their dose a little bit, try to get them understanding how important it is. And often it'll work. Some people just aren't going to make it, but a little bit of a hint of you got to get a little bit better will sometimes work. Our incentive programs really helped a lot. So we would make goals with each patient. If they attained those goals, they could get like some gift certificates, gas cards, books, and they really liked that. and the integrated care again. So once we did all that, we increased our second visit up to 90%. We're at 40% at 4 months, 37. And actually, we just redid our numbers. I think we're at 40% at 1 year, which is pretty amazing if you've ever had anything to do with heroin addiction. So, it's really not as bad as people make it out to be. Just to finish up, so this is the new guy in the block that's going to be available around April, which I think is going to be a real game changer. This is subcutaneous buprenorphine, and it's going to be a monthly shot. Basically, it goes into the abdomen. It's a sub-Q shot. It forms a little ball of medicine that works for a month. So it's really going to decrease the illegal selling of it. And I think it's going to be a big change. I'm sure we're going to have difficulties talking kids into it, but if they try it, and they have shown the drug levels are actually better than even you get with the sublingual medication. Vivitrol we didn't used to use so much, but I'd say maybe 10% of our kids are on it. I think it's not, to me, great for somebody that's actively using and is starting to try to get clean. You got to have them be clean for like 10 to 14 days without any opioids before you can give the shot. So it tends to be kids that have failed outpatient buprenorphine several times. Maybe they got arrested and were in jail for a couple months, so we'll get them into our clinic as soon as they're released from jail and get the shot in them. And some kids do say they feel better on it, that there appears to be some sort of decrease in craving. And it absolutely is good harm reduction. I mean, you're not going to die when you have that in your system. So I think a lot of times what we're doing is harm reduction. We're just trying to get people older so they can grow up and make better decisions. And every month you can keep somebody alive, there's a better chance they're going to turn it around. So I think prevention will work. I wish we were doing a lot more of it. Treatment does work. People actually do recover, and it's amazingly rewarding when they do. Really makes a difference. So that's pretty much everything I have to say. Glad to answer any questions.
Thank you. That was a great informative talk. So I will field questions, any from around the table or out there in cyberspace. I did notice a comment from one participant out in cyberspace that said, noticing that maybe cigarettes and alcohol might be the first drugs used by teens rather than weed. And do you have any comments on that?
Can you repeat it? I got lost there a second.
That cigarettes and alcohol seems to this person would be the first drugs used by most teens rather than weed. And do you have any thoughts about that?
Yeah, no, I agree. I just think alcohol doesn't have the same effect. So, I mean, obviously, it would be a great place to short circuit that movement. But, I think we know, almost universal alcohol use during adolescence. And it's, kids aren't sitting around with their pinkies up chatting around a cocktail. They're binge and drinking, and that's very dangerous. Obviously, that would be a great place to intervene. To me, I think the high you get from marijuana is different, and it's more potent. So, I think it's really that first big step to going on to something more dangerous. It's almost like we've given up on alcohol. I think people hear it and it's like, well, everybody drinks, I guess that's okay. But obviously it would be great to have a system that really addressed that early on and tried to get kids to not progress from there.
Yes. I don't know if you noticed, Dr. Matson, but in the news the last couple days was some information that the Trump administration has made it easier to access opioids. And I wondered if you had heard that or had any thoughts about how that might not be so helpful to what we're dealing with across the nation. I come from the space you do about if this was some kind of illness that people could see physically and, you know, thought of it as a physical sickness and not, you know, you're an addict, that we would be approaching it differently. And so it seems counterintuitive to want to make it easier to access opioids.
Yeah, you know, you can sort of see some people really do need those drugs, and, you know, they just need to be supervised closely and make sure people have real pain. They need the medicine. So, although I doubt that our present president is thinking that way, you know, I do think it's important that we make it available still, but in a more careful way. But, I mean, we know virtually everyone. I mean, the sheer number of opioids that are just out there in people's cabinets, you know, on their buffet, on their dressing table, it just blows the mind. And although we have decreased the amount of opioids being prescribed, the sheer number is still just crazy. You know, you see numbers like it's enough for everybody to get like 50 pills in the country. So, I think even here, one of our young colleagues is working in the hospital here to decrease the number of opioids that are being prescribed. And, you know, a lot of them tend to be surgeons who are used to people being in pain and sending them out, but they've looked at things. They actually did a little study looking at like appendectomies, and they called the homes, and most of the kids used like none or one or two of the opioids, and that they were perfectly fine just with some ibuprofen and that. So they've actually convinced our general surgeons to just send them home with 5 tablets. And I think that's an amazing thing. And other places are starting. I sort of laugh because this is what I do for a living. I just had my knee scoped, and my surgeon sent me home with 60 Percocet. So it's pretty nutty with all this going on that people are still doing that.
Yes.
Wow. You know, I saw that same headline, but when I read the article, what they were objecting to was that the Trump administration, and I don't know which government agency, was actually extending the prescriptive rights to NPs for prescribing buprenorphine.
Oh, right.
Well,
So that to me should actually, and here in New Mexico, I don't want to say it's been the past year or two, that New Mexico has given NPs prescriptive rights in their under their DEA to prescribe buprenorphine following a very intensive training program.
Oh, okay. So
that to me seems like it actually might be a net plus.
Yes.
Right. Of course, there's always the double-edged sword. What happens sometimes is some unscrupulous doctors will hire 5 nurse practitioners, and they'll be seeing 1,000 patients. So I think I'll trust a nurse practitioner more than a doctor probably. So hopefully they won't get into those situations. But we just did a study here in Ohio. And it's actually very rare to be able to go to an MD and not have to pay cash for the buprenorphine treatment. People have just opened up shops separate from their practice. So there's some bad stuff going on out there, you know, and we really need people that are dedicated to doing things the right way to step up and participate in this. We have a really difficult time finding a provider to take over our patients once they are doing well, and because of that we still have like 30-year-olds in our clinic because they can't find anyone that will take them over without charging money.
Yeah.
And I'm curious, what's behind that? Do the payers not cover it? Or, I mean, I would think would expect that caring for these young people would be a very time-consuming. I mean, you're really not discussing a 10-minute visit.
It's not, yeah. And so, I mean, you know, that worries me too. We have these little, they call them Suboxone 5 clinics that kind of pop up in apartment complexes around here, and they just have people lined up out the door and they all sit down and talk about their use for 15 minutes and then they leave with their medicine. So the cash business is, you know, that you can get in trouble for Medicaid fraud if you're taking cash for some things and not others. So basically, they totally ditch any insurance and just do it for cash, and then they can't get into as much trouble. They're obviously supposed to have limits. Even people who've been doing it for a while shouldn't be caring for more than 100 patients at a time. My group of 4 people can barely handle 60 at a time, so I don't know how people think they're doing a good job, although I think some people might actually do. I sort of think of myself, I was a heroin addict, I think I could probably do well because I don't want to lose my medical license and everything, but so I think maybe some people have the situation where they could do okay just with the medication, but I don't think that's the norm.
So if you manage in your clinic with your 4 providers 60 patients, do you have a wait list? How do you deal with? Oh.
Yeah, we do not have a wait list. I think, hopefully this won't get back to my institution, but they don't exactly put it on billboards that we're treating heroin addicts at Children's Hospital. So, I think there's a lot more people out there that could use us, but it's really gets to be word of mouth and treatment centers that send us patients. So, it's another little hurdle to jump over that, and that's why I try to push that prevention message. I mean, it's really, all this stuff is happening on our watch at Children's Hospitals. So, it would behoove us to put a lot more effort into the beginning rather than having to deal with people when they're in such terrible situation. And most of our, because of we take Medicaid, we get really hard cases, people that are living out of cars, people that, we have kids whose job it is at home to inject all the adults with heroin. So the environment they're going back into is so bad that it's a wonder anyone gets better sometimes.
Yeah. Any other questions from out there in cyberspace or here around the table at Envision?
And I'd say, for people that want to do this, I think you really can do it with a nurse, a social worker, and a provider. So it's not that money intensive. You need a group of people that really care about these kids and can meet them where they are. And you got to probably have some time set aside to do it. So I think it'd be really difficult to see one of these patients right in between 2 sore throats and an ear infection. But, if you set an afternoon aside or something like that and kind of had the team together, I think you could start small and enjoy it and really see the sort of good you can do.
Thank you for that.
And Dr. Matson, would you mind advancing the slide for me? Let's see. So while we work that out, just so you know, if you haven't announced yourself through the chat box, go ahead and do that. I'll leave the room open here for just a few minutes and make sure that you're marked down. I think I have everybody. And also, I just sent out to everyone through the chat our survey. It's very short, and it does help us improve our telehealth offerings here. So if you have a minute, we'd really appreciate you doing that. Just click on it and fill it out. It just takes a couple minutes.
And I'll send a copy of my 2 videos so you could watch them. They'll make you cry at the end, so it's worth looking at them.
Well, thank you.
Thank you.
Thank you so
Tears
much.
of joy, not unhappiness.
Yes. Thank you so much. That was such a good talk. And like I said, it makes me feel hopeful that we could find an approach to deal with this challenging issue. And just got to find people that are really okay taking care of teenagers with a really challenging problem. So
yeah.
Thank you so much for your time, Dr. Matson. We really
appreciate it. Pleasure. Thank you
Everybody,
very much.
have a great day out there
You
in
too.
cyberspace.
Thanks.
And remember to sign up for Adolescent Health Initiative certificates. We would love to share more information with you about taking care of teens.
Thank you.
Thank you.
Are you guys still there?
We are.
Should I try to answer some of these questions that came in, or?
Let's see. I don't see any. We have some questions about the.
Oh, somebody answered it already, the Sublocade. Yep.
Oh, yes, that one was answered. That's why I didn't bring it up. And just some comments from Sean. It was sent to me, actually. Thank you so much. That was an inspiring talk.
You kind of lack that interaction, but it's interesting way to do things.
Yeah, you do lose a little bit of that through telehealth. We love to be able to get people on camera. That's part of why we use Zoom. It might be the 8 in the morning thing, or it's just one of those things that we have to study further, that people just don't like being on camera.
It's kind of intimidating, you know, to turn on your computer and there you are looking at yourself.
Yeah, that's why I don't like mirrors.
Yeah.
I think we'll get there. It's one of these cultural things that everyone just kind of has to get used to it.
It's kind of funny though, given the selfie, the people with their cameras like crazy posting pictures of themselves here, but they're not gonna get on camera for a great talk. I don't know.
And as Colette just mentioned too, that she was just not able to get her camera to work. So, or maybe doesn't have a camera, or a lot of things get in the way there. But at least we can do this, and you can present from Ohio, and we can be here and still enjoy a real-time conversation.
Yep.
Well, yes, and we had people come in from all over New Mexico, like far away, Carlsbad, Roswell. We had some people from Espanola, which was interesting because you talked about, what that being one of the hot spots. So I'm glad people from distant locations away from the university are able to get this kind of information and maybe do some transformation in their own practice.
Are the talks saved so people can look at them later if they want?